Well, hello everyone, and welcome to the UCLA Center for Health Policy Research's 2014 Health Policy Seminar Series. My name is Gwen Driscoll. I am the Director of Communications here, and it is my job to encourage you to sign up for Health Policy News, our free monthly e-newsletter that will not only tell you about our upcoming speakers, but will also alert you to new center data and research on topics ranging from healthcare reform to childhood obesity. You can sign up outside for those folks who are here in person, or you can find us on our website at www.healthpolicy.ucla.edu. And with that obligatory plug out of the way, I'm delighted to introduce our speaker for today, Dr. John Øvretveit of the Karolinska Institute in Stockholm. Now, John has insisted he would like to introduce himself, so without further ado, I'm just going to turn things over to him. John.
Thank you very much. Welcome everyone, and people remotely, and in the future who may look at this. I'm very pleased to be invited to kick off your 2014 sessions. Very pleased to be invited to the Department of Health Policy that is doing some groundbreaking and really, really important work building on Rick Bound's vision of what was absolutely needed, the data that you have. I'd very much like to thank Jerry Kaminsky for asking me to present this. I'm with two groups here, with the Veterans Health Administration, mostly based at Øvretveit, and the Department of Public Health. And I'll be doing sessions and teaching there next week, and have been. So to the topic today, patient-centered care. Well, how else could care be if it wasn't patient-centered? What's the issue here? I'll hope that will emerge as we go. But first of all, what I'd like to do, and I may need some help in different things. I'm pressing.
You can click on the bottom left arrow on the screen.
Oh yes, of course. That one. So, or do you mean that one? Do you mean that one?
Nope. No.
That one?
Yes.
No. Not happening. Sorry. Oh, thank you. Yes, great. What I'll cover is what I've called a movement, which is primarily often very angry and upset patients, but not always. Some enthusiast physicians and healthcare providers and others. I'll be giving a fair bit about evidence of whether there are effective ways to make healthcare more patient-centered, and I'll be looking at some of the evidence about whether these ways to make patient care more centered on patients, whether they actually save money. And the issue here is very much, well, save money for whom and when? And I'll explain that. That's the key question there. And then I'll do some looking to the future and prospects. First of all, I'd like you to invite you to think about your own organisation. And this is a sort of in putting this together, this is kind of a test that I gave myself. But I thought, well, actually, it's good for you to think about your own organisation. There were 3 questions to think about, but let's think about your organisation first. And the questions are how much your organisation, be it a research institute or a healthcare service, may be working with patients, clinical-based service, or it may be an information service to patients, how much it is truly patient-centered. In fact, may I quickly ask, are there any people who see patients at least once a week? Mostly research and policy folks. Okay. So it still relates to us because I did the test myself on our units and our research. -1 is worse than nothing. It's indifferent. You know, this isn't really relevant to us as researchers. You know, it's a whole other thing. Beginning awareness, and you'll hear the term used about our research, is it patient-centered? Examples and planning. So could we give examples of how some of our research is patient-centered? Definitely sometimes. So there's an increase in certainty. Some activities manifestly do take a patient-centered approach. And yes, and we can show it. We can give measures of how patient-centered our research is. We can give numbers. And we can show how it's varied and increased over the years. And 4 is, well, you clearly don't understand the concept because you need to ask patients that question, not us. So those are the scores. Now, I realised that I think most of our research was a beginning awareness, but there were examples where we complained about essentially their ethics committees, but I think you call them here IRBs, that we have to go through. But it's mostly a complaint rather than it's the right thing to do. So I would say our research is sort of 0.5-ish there. Any here who would say, well, actually, I'd say it's -1 for us. Any beginning awareness in our department? Anyone for, yes, we can give examples. Okay, so we've got a couple on one. Okay. How about definitely someone? Okay, so we've got a couple there. Yes, and we can show it. How about this one? Ask patient. Well, okay. By the end of this session, I hope you'll be able to answer that question because maybe at the moment you're a bit puzzled. Well, what do you actually mean by patient-centeredness? And that really was to get us going and thinking about getting us started on this. So, I think probably the best way is to show you this, and let's see if we can get this going. Right, and this is one view.
ACOs, Accountable Care Organizations.
I don't think we want that.
To introduce our panel.
We want Don.
I fear to be a patient. Partly that fear comes from what I know about technical hazards and the lack of reliability in care. Today I have bone-on-bone pain and osteoarthritis in my right knee. I can no longer jog, which was my passion, or even run 4 steps because I had an unnecessary and now fully discredited knee operation as a medical student, an operation that has never been subjected to proper evaluation for a condition that has never been subjected to a hands-off arm.
Would it be possible to have it a bit louder so people can hear it?
Complication from a drug dosing error at a transition that almost killed him. I was certain.
Lost sound.
Lose it.
For fighting errors and unreliability, I am aligned with the good hearts and the fine skills of my technical caregivers. I can use my own wit to stand guard against them. What chills my bones is indignity. It is the loss of influence on what happens to me. It is the image of myself in a hospital gown, homogenized, anonymous, powerless, no longer myself. It is the sound of a young nurse calling me Donald, which is a name I never use. It's Don. or for her, maybe it's Dr. Borov. It is the voice of the doctor saying, we think, instead of I think, and thereby placing that in that small verbal wedge, the pronoun we, between himself as a person and myself as a person. It is the clerk who tells my wife or my son to leave my room, or me to leave their room, without asking if we want to be a part. A close friend called a clinic for a mammogram report, and she was told, you have to come here. We don't give that information out on the phone. She said, it's okay, you can tell me on the phone. And they said, no, we can't do that. Of course they can do that. They choose not to do that. And their choice trumps her choice, period. That's what scares me. It scares me to be made helpless before my time, to be made ignorant when I want to know, to be made to sit when I wish to stand, or to be alone when I need to hold my wife's hand, or to eat what I do not wish to eat, or to be named what I do not wish to be named, or to be told when I wish to be asked, or to be awoken when I wish to sleep. You can call it patient-centeredness if you choose, but I suggest to you this is the core. It is that property of care that welcomes me to assert my humanity and my individuality and my uniqueness. And if we be feelers, then I suggest to you that that is not a route to the point. It isn't.
Okay. How do I get back to the PowerPoint? Okay. I hope you're able to hear some of that. What Don was emphasizing was, well, certainly from a Swedish perspective, it's a very individual approach, and it really challenged me to think about now, well, for me, coming from Sweden, watching that, there were two things that struck me. Is, first of all, is he overemphasizing the individualism here? Is he being a bit precious? Now, that probably doesn't occur to any of you. Being born free Americans, you know, this is the purpose of the country, isn't it? But for me, it's sort of, well, that's being a bit precious, isn't it? The second thing was, well, it's all very well, but it's going to cost you a lot more to do all of these things. It's going to take up people's time to do it that way. They may prefer to do it. Maybe they may enjoy giving better care that's more individualized, but it's going to cost more money. Those were two things that struck me. And it led me to think about, is the emphasis on individual, providing for the individual and taking account of all the individual preferences, absolutely important, but is there a point at which you may go too far in this? And certainly if you're in a healthcare system where it's a tax-based system, and where going so far with one patient takes away resources from other patients, where there is a limited pot. There are issues there that present themselves to the minds of those of us in socialized medicine that may not present to your way of thinking. So, and it's also a bit related to the Universal Declaration of Human Rights. When I'm in Yemen, we had an EU project in Yemen, I often think of that as being a very Western document. Whereas when I'm away from Yemen, I do think, well, yeah, these are universal things about individualism. So I don't know. I'm just aware of the issues there. So, and I also note that the Swedish, I wouldn't say it's a law, but the regulation and policy on patient-centered care in Sweden puts, first of all, equality. Patient-centered care is treating patients equally. That's the first. Secondly, is treating them to maintain their dignity. And interestingly, they put third, and in relation to the individual's autonomy. They don't say individual needs in preferences, in terms of individual autonomy, which is a slight translation of that. So that may be slight evidence for my sort of cultural, casual observation that actually there are slightly different values as regards individualism here, going on here. A second issue that it presented for me is, I'm sure you've heard the concept of mass customization, that more and more service or products are about providing an individual product to what the individual wants on order, but to be able to mass produce it in that way, in a very efficient way. So is it possible to use some of the ideas and principles and methods of mass customization in healthcare? And what Don is talking about is, I certainly would prefer it that way. That would be nice. But I'm not sure I'm prepared to pay 2, 3, or 4 times more than that. In the same way that, given that the difference between economy and business is 5 to 10 times, I'll just tough it out back there in economy and look how much money I'll have to spend when I get there, kind of thinking. I may decide that differently for health, because I may give health much more importance. And it may even be life and death and whatever it takes to get me through this, that I may pay more or value more. But the cost, we have to have cost in the equation. And that then leads me, I was not happy with the definitions that I found of patient-centered care. So it led me to this definition, and it relates to the points that I've made. I would say patient-centered care is meeting an individual's needs and their wants, needs being a code term for professionally assessed needs, and wants is your wishes. So it's combining professional and patient preference, as far as is possible with the available resources and technology. So it's saying this isn't unlimited blue sky, it's within constraints. And it's also recognizing that more for one patient is less from another. And that also, to a certain extent, applies in insurance and the direction US healthcare is going. I think a very important second thing that I would like to add is patient-centered care is an enabling patients to self-care. Because I think the important thing is that that as clinicians we shouldn't act as hosts of the patients, but we are guests in their lives. That patients, of which we all are at certain times, choose for a brief moment to invite the healthcare system and physicians into their lives for what it's worth. And they will only make this choice if things are so grim and so bad that they are prepared to go through the hassles and pain of, well, just contacting a healthcare and trying to get an appointment without then the rest of the ride. And remember that we, patients, can get off the train at any time we want. We can turn away and go. So one of the things that healthcare will need to do, I think, if it's going to be more patient-centered, is to recognize that each of us has busy lives, and we need to be enabled to self-care and to be less dependent on the healthcare system and on physicians, and more self-determining. And what is the healthcare system doing to enable that? Well, I think patient portals, those of you who are signed up with Kaiser, or I doubt whether there are any VA folks here with My Healthy Vet, but those patient portals are a move in that direction, although I think they're primarily a way to cut costs. And again, there's a balance here because, and the way I would put that balance is as wanted and appropriate. And it also includes informal carers, because most care is provided by us to our families and by others who are not paid, who help us get through in different times. But as wanted and appropriate is to recognize that each of us, even in the course of one illness, there are times where we actually do not want to self-care. We want to just give in and go to sleep and let someone else deal with it. And it's not self-care is important for longer-term and chronic diseases, but it's not relevant if you've been in a car accident and you're unconscious. So this is an important dimension, I think. And then the third one is, that's as it were at the individual level, but I think this is extremely important, is part of the issue is that a lot of health services, the facilities, the patient pathway through the service is simply not designed for patient-centered care. It is designed primarily for the convenience and efficiency of the system. And a lot of this is about the trade-offs between the cost and how individualized it is. I think to look at the patient-centered care movement, you always have to say, what are the trade-offs and what are the higher priorities here? And why now is an important question with the patient-centered care movement. Why is it gaining momentum and traction now? Well, because the balance has gone too far the other way, I think. That's one of the explanations. And it's seeking to readjust the balance because, surprisingly, the 20 years of the quality improvement movement has not really made care a lot more patient-centered. So it's in a sense, well, okay, you've done your thing with quality improvement, but I'm sorry, it's not working, is it? We need more than that. Now, others in the quality improvement movement would put a good case for why, but maybe it's just another go at the issue. So let's get into a bit more about, well, what do we actually mean by this? Well, when we've got a vague abstract concept, the question always is, how would you measure that? What would you see to judge whether it's there or not, or how much of it there is? One approach, looking at the broad level, is the Plane Tree, and Plane Tree have been an important organisation in the States in leading patient-centered care movement. There is, on their improvement guide, a series of questions, and it's fairly rough and ready, judgment-based, but it's a move towards measurement, and you can download that from the Plane Tree website, and there is a self-assessment tool to apply to an organisation if you want. I'm going to move on quite quickly. This was to get you to lay your bets, and I'm sorry the transitions didn't work, but the first question to you is 0. Well, now we've got a bit better sense of what you mean by patient-centered care. Here's where I'll lay my $100 bet in 5 years' time. I'd like you to think about where you put your hands up, and imagine I'll be back in 5 years and we'll distribute the money and work it out. First of all, this will not last. It will pass. It's nothing new. You get fads and fashions. It's not really serious. So basically, in 5 years' time, not much will be different. The second bet is my organisation will be doing a bit more on this. So here we're focusing on research. Secondly, my organisation will shift considerably to a patient-oriented approach it will be a greater part of my work. So we'll be seeing more patients taking part in the research, in planning it and advising it. Would you lay your bet with that one? Or would you lay your bet on this one? This will have a major impact and significantly affect my work in 5 years' time. Right, let's make your minds up. Time number 0. It won't, no difference in 5 years' time. This isn't a wish, this is where you put your money. 5 years. Any hands up for that? Okay, okay, 2 hands up. 2 hands up. So that's about 7%. My organisation will be doing a bit more on this. Okay, two hands up. My organisation will shift considerably to a patient-oriented approach. Okay, three for that. That they think is going to be. This will have a major impact and significantly affect my work. So we've got 2 there. So this is clearly a group of researchers, which is quite a few really shrink back from making bets and recommendations. That you forgot the other question, John. It depends, or what do you mean by, etc. Other qualifications. Okay. But thanks for the growth. So fair distribution there. Here's one example. This is an 84-year-old woman, and she's stable at home with her motivational coach and security guard, a black cat here. And if ever there was a good return on investment, it's the cost of an animal for an older person. They can choose whatever they like. And I think even the maintenance costs for that animal, although I shrink at veterinary surgeon charges in the US, but I think that would definitely pay back. Anyway, so I haven't got a lot of time to get into the detail, but this is that lady's experience, and this is in the British NHS. So for those of you who follow Fox News, you'd say, well, we wouldn't expect otherwise in the British NHS. They're still fighting the Second World War over there. At 10 a.m. she fell and broke her hip. There was quite a while before she was actually admitted. It took a while to get the radiology, and indeed, yes, she has broken her hip. So we find a bed for her. Saturday and Sunday, well, they don't do operations here at this hospital. She wasn't transferred. Monday, the surgeon was informed too late to put her on the list. So 4 days after the hip breaking, she had an operation. Friday, she was isolated due to MRSA on her arm that was connected with the fall. And a week later, she was sent back to primary care, and primary health care were not informed about that. I won't go into the details, but a neighbour kindly visited and discovered and found she was not doing well. She was able to contact the nurse from primary health care to visit. The nurse wasn't able to, the antibiotics she was using were not the best, and she had to be readmitted with weight loss, pneumonia, and an open wound 2 weeks later. Now, if we just look at the monetary aspects of that, would you like to guess the cost to the healthcare system? How much did some of the delays, errors, suboptimal care cost the healthcare system? We could list 10 or so particular adverse events, or that shouldn't have happened, that shouldn't have happened, and each of those have a potential cost. And you've got 4 choices. Would it be under $2,000? So what we're saying is, if it went smoothly, they would have saved $2,000. Would it be between $2,000 and $4,000, or between $4,000 and $10,000, or are you being good research and saying, well, it would actually depend how much you would have to spend to fix that system to do everything better or right. So we can't choose here unless we know how much the solution is going to cost. So who would go for, well, that if they did it right, they'd save if the problems that happened would probably cost the health system $2,000. Any hands up for that one? Okay, how about between $2,000 and $4,000? How about between $4,000 and $10,000? So we've got, great, thanks. So we've got about 50% on that one. This is clearly America. I tend to go for this one, but this was a rough back of the envelope calculation. It's in UK language, it's this. But I do note that the hip replacement in this country costs, well, by one estimate, 10 times more than it does in this country. Okay, this is what we cannot quantify with the adding dollar cost to it. And you probably can't see this very well, but that's two pictures, one 6 weeks later, and one of my mother's British friends said, you know, John, it really knocked the stuffing out of her. Basically, the brightness of her eyes significantly dimmed after being through that. Now, you may say, well, actually, preventing falling over and breaking your hip and osteoporosis, prophylactics is the better way to go, rather than fixing the healthcare system. And I think that's a good point. But what I'm saying here, really there are 2 points I want to underline by this. That each of those errors and lack of patient-centeredness had a cost to the healthcare system, but it certainly had a cost to the patient. And if we just focus on the money cost to the healthcare system, in theory, you can see being more patient-centered would save some money. The second point would be, yes, but you have to spend money to save money. And some changes or interventions are much more expensive than others. And also, how far do we go down the road towards individualized care, because it costs more and more the more we do that. And we'll come to that shortly. How would the average nurse vote in the USA? I grew up poor and have an allergy to waste, so this is also looking at the motivations of staff in healthcare to make their service more patient-centered. And what we just saw was a fair bit of waste in the system. And these are some of the questions. This is an important one, that if we reduce that waste, would we be able to retain some of those savings, at least for our department, to spend it on things in the department, the incentives? Now I'm going to move on quickly, but these are some of the questions related to the staff and the motivation issues. What I'm going to do is just give you a quick run around some of the research in this area, and I'm mostly drawing on this recent study. All of these are free downloads from actually a British organisation called the Health Foundation that has more recently done a lot more work on patient-centered care and has funded research and practical projects in this area. They have a very good website called The Health Foundation. And this being America, I'm allowed to do this, do a plug for a book that's available on Kindle that also gets into some of those issues. This is what to do about it. Now, your experience, before we go into the evidence, let's think about your experience. First of all, generally, I understand what doctors tell me I should do about my health problem. Yes or no or partially. Hands up for, yeah, I pretty much get it all. Okay, all right. Well, fine, that's most people here. Some of you may have a clinical qualification that may help. Any definite no's? Okay. I think if they said in their gentle way, by the way, you've got cancer, and this is what we're going to do about it, you may walk out and answer that question differently. Okay, moving on. Generally, I've found it easy to work with my doctors to manage my health. That's interesting. Again, these are pretty vague kind of questions, but generally, who would say, yes, we can talk about working with my doc? That's interesting. Okay, so that's about 50% of folks here. I'm tempted to ask which system you're with or which doctors, or I'm quite curious. How about, no, it's not, I would say working with my doctor to manage my health, no. Okay, thanks. So we've got one there. How about partially? Partially, yeah, okay, thanks. How about this one? Generally, my health service gives me good support to manage my health. Who would say yes for that one? Okay, we've got slightly less than the others, about 30%. Who would say no? I wouldn't say they give good support. So we've got slightly more than that. Partially. Okay. All right. So a lot of people think it's mostly in the middle there. Now, this question here is getting into an important aspect of this. Would any of the above answers be different for people with less education than you have, or undocumented folks in California? And do they need less help with their health than you do? And I'll just leave that hanging there for you to think about. I think it's all very well for us as educated, knowledgeable folks in this area, and actually, in the scheme of things, although we don't feel it, very rich, healthy people, than people with less education who have 2 or 3 jobs just to survive, and may only have partial understanding of English, and also are worried about even going to the ER room for fear of being deported. Okay, is there a problem? Now, let me tell you the way I approach these reviews. Basically 3 things. The first question I said was, okay, what's the size of the quality problem? How much waste is there? How big's the problem? And are we able to attach monetary costs to that, to suggest that if that problem didn't exist, we would save this amount of money? So the cost of the problem. So an obvious case would be adverse drug events. That has quite a high cost in terms of treatment. Another one is patient falls, where patients fall over, and some of those are serious and actually need operations. That is a problem that we can quantify, and we can add monetary costs to that. To whom? Well, we're going to get to this. The second thing is, well, okay, if that's the problem, what about the solution? is there an effective a solution? Because sometimes some problems there isn't a good solution that actually works. So that's looking at the evidence of interventions and effective solutions. And then, well, has anyone worked out how much these solutions cost? So you see I'm doing it at two levels: quantify, then add money numbers to it for the problem and the solution. And then the third bit of this is, well, okay, if you spend that amount on the solution and reduce the problem by 50% or more, who saves money? Who has to spend? Who saves? And when? Because it may take a year, may take longer to pay back. Good example is immunization and other sorts of care. Low cost, there's a problem, people get this, we can prevent it, this is the cost of the solution. Okay, who saves money by, who spends money on funding immunization, who saves, and then, but when do they save in terms of the different stakeholders and players? And that's a very simple way to do these costing calculations. So first of all, we're looking at the size of the problem. When asked by their physician to restate the physician's instructions, low literacy US diabetic patients respond incorrectly 47% of the time. Now, the question, of course, is it serious? But what it is showing is that there is an understanding issue, and sometimes it's potentially serious. Now, that's an example, and here are a few of the other ones, and I'm not going to get into it further. There's a fair bit of research on people understanding prescriptions, how often, what dose, and so on. Next, this is going on to the solution. Now, does anyone know what that is? Okay, it's urinal. And can anyone see that? That's a fly on a urinal. And, sorry, what? Is this suddenly getting surreal? What's he talking about? Now, the point here is that adding that fly to the urinal reduces spillage, and they measured it by, actually it was over 90%. Actually, has anyone been to Schiphol Airport, Amsterdam? Yep. Okay, so exactly the guys here would know about this. I mean, actually, you don't need to go to Schiphol to get this as a guy. It's obvious, you know. It's a guy thing, basically. Now, we don't have to go into the theory of the male psyche and why it works and things like this. But the point is that this is a very low-cost solution, and you save a lot of money from it. And it's to illustrate the dynamic between the problem and the cost, and the solution and the amount of cleaning and everything. So they had installed these urinals and actually stopped the order and delayed and ordered all the others because it was such a winner. And it was invented by one of the toilet cleaners in Schiphol Airport when they looked at ideas. Okay, here's another one. Now, this takes you to the Karolinska Hospital. We're an academic medical centre, and across the road from the medical university there's the hospital. And a team of medical students one night inspired by this Far Side cartoon, which is a bell ringing in a restaurant when a man walks out of the Actually, I'm realising there is a bit of a theme going on here about washrooms, isn't there? Walks out into the restaurant and a little bell goes. Didn't wash his hands. Now, the point is that there are two toilets in the Karolinska Hospital that had those fake security cameras. Late night, two of our medical students put this in, poster on the door, going out, and this adding the face recognition software records pictures of people not washing their hands. The face recognition thing really did make a difference. And the point is that this is a low-cost way to persuade even male doctors to wash their hands more than they do, which is a big challenge worldwide. And if it saved 1 or 2 infections, the cost of those fake cameras and the poster was well worth it. So the point here is emphasizing that dynamic. Now, there are 2 levels. There are a number of different levels when we're looking at patient-centered care. One is in the encounter between patient and physician. Another is in the facility, if the facility is patient-centered in many ways. And a third is in patient pathways and how it's organized. A lot of the research is on communications and patient-physician encounters. Here's an example of interventions that reduce waste and raise quality. So we find that patient adherence to treatment is 1.6 times more likely after certain types of training, physician and communication skills. And the key issue here is what type of training. And really it's role play, video, practice, rehearsal. That's about the only one that works. And then it varies how much it's sustained. You also need to measure and show that patients appreciate it and feed that back to the clinician to sustain that. So I won't go into detail of that. Do any save more than they cost? Here are a few that do, and I'm not going to go into a lot of this. These are patient-centered interventions that really do save a lot of money. And I'll move on quickly because I wanted to get to some other points. Supporting self-care also, there are some important interventions there. The Lorig, Stanford, the refinements of that work very well. So, some of the conclusions. The conclusions from those review were, as usual, the limitations of the research. PCORI, who you may or may not have heard about, have got recommendations for patient-centeredness, and they are going to assess proposals in terms of how much your research is going to involve that aspect. Generalization, and I'm going to come to this is why I'm speeding up, because I want to talk about, well, okay, that's very interesting that if you use that intervention in that medical center, would we get the same results? Could we reproduce it? And would we get the same results with our patients in our setting? And I'm going to come to that. And the key issue about, we need to look at budgets, not theoretical savings, because in order to realize savings in budgets, you often as a manager have to say, well, okay, now we've freed up time or beds. We need to convert that into savings in the budget. And we have to redeploy people or close beds. And there is a second cash change that is often forgotten by researchers when we get to this. So, payback, it could cost your organization up to plus or minus 50% as how much it costs these other organizations. A lot of it depends on how well you're able to implement some of these changes. And more of that is said in the reports. this is a way to remember these ideas. The evidence of the intervention is the seed, it's the idea. The gardeners is your project teams in the organisation actually implementing, getting the change in place. And if you've got skilled and effective gardeners who carefully nurture the intervention, then that's helping. But a lot depends on the soil, which is your organisation environment, the culture and attitudes to this. So if you have a culture that doesn't really value patient-centeredness, like a lot of academic medical centres, it's not going to get very far. And then the climate is really your regulation financing climate. So do you have accreditation or inspections that emphasize patient-centeredness? And does the financing system reward patient-centeredness? And that's what my rough and ready 10, 20, 30 change success rule. The idea is only 10%. This evidence is only 10% of what counts. Personalities, 20%. The implementation is 30%, but 40% of it is whether you've got a receptive environment for the change. So here's an example of that. Basically, if you're, a very simple way to put it is, often adverse events reward the hospital under some of the older payment systems. That essentially, well, another way to put it is, oh, surgery left an instrument inside the person's abdomen. Fine. Person comes back, we can charge for x-rays, we can redo the surgery, and we get reimbursed for all of that. So about 5 years ago, CMS said, actually, if you have to do another surgery because of an instrument that you left in there, that you're going to dig out again, we're not going to pay you. We actually do think we shouldn't have to pay twice on that. Outcry, uproar. But since then there are 30, 40, 50 of those, and the one you probably know most about is the avoidable readmissions within 30 days, and some of the other infection ones. I'd like to play you this, and I'll be finishing shortly, but and I do hope people can hear this, because this is worth hearing. Could we have it so that people could hear this?
Right. Dr. Annie Brewster is an internist in Boston, and she was diagnosed with multiple sclerosis over a decade ago. But when a doctor prescribed some very intense medications for her, she decided to push back and say no to her own physician.
So I was first diagnosed in 2001. I went in and I was told that I had probable MS, and I was told to start disease-modifying therapy immediately. Initially, I actually sort of ran away from the doctor's office because I wasn't ready to hear that, and I didn't go back until 2005, and actually didn't start medicines until 2006. I never felt that there was much of a dialogue about options. It was sort of disease-modifying therapy, medication, or nothing, and I never felt that I was presented with other forms of management, such as diet or stress management or sleep improvement or things like that, that maybe aren't as clear-cut and haven't been measured, but I think certainly can help with diseases such as MS in particular, which are autoimmune. I have to say that I wasn't very good about pressing the issue. I mean, I left and I didn't go back, but that wasn't really dialoguing with my physicians about my ambivalence. I didn't feel safe to do that for some reason, and I definitely take some of that responsibility. But I think it's interesting that I think a lot of patients don't feel that they can push and ask questions and disagree. So I was on 3 different medications since 2006, and the most recent experience I had was a once-weekly injection, and I did it for 3 weeks, and I was so ambivalent I didn't sleep well because I had such a bad headache and I had such bad body aches, and then I lost the whole next day because of fatigue and continued body aches and headaches. And I had felt really, really well beforehand. So for me, it just seemed suddenly more clear-cut because my symptoms had been so mild, having been sure that I really needed that medication. I think quality of life is really important. And most recently, when I was started on this medicine that I had the really bad side effects to, I again didn't really feel like the context of my life was being fully understood. And I did try to express that and say, I don't really have a lifestyle that's going to allow for me to lose 2 days. I'm working, I have 4 kids, I'm busy, and that's important to me. I'd rather feel good in the day-to-day right now and risk the chance that maybe my disease will progress than feel crummy when I don't even know if it's helping me. I really struggled with that decision, but I am going against my doctor's advice, and it's made me think a lot about how to change my practice as a physician and how to better serve my patient. But I think there is a...
I'll finish there because we're running over time, and I'm sorry I've run over time. The last thing I'll say is that and some other things in looking at the literature on this brings back to this sort of point that I note, that even when healthcare providers and researchers start looking at patient-centered approaches, they're still very much concentrating on outcomes. And even if it's more patient-oriented outcomes, like patient-reported outcomes. But that interview and most patients are simply saying, look, one of the issues here is the treatment itself, whether it's a treatment for an illness that you have or preventative treatment. If that there is a trade-off between how that makes me feel and how that affects my life and what the benefits are. And people don't tell you about that. And providers are often focused on cure or the end outcome. And they know very little about, one, what it feels like to take that medication or go through that treatment. And two, how that disrupts and interferes with my life and how I'm living with it. And related to that, interestingly, many doctors who get cancer, many of them say, look, I know, given my 30 years as an oncologist, I know what this ride is like. And actually, I'd rather manage the symptoms and not go through that treatment and live my last few months or years as me rather than as half me. So really what I'm saying is the experience of treatment and how it affects the life that I live, which may mean, a lot of appointments, the disruption of your life. People are often, and it's like that doctor, often willing to say, actually, I'd rather just break free of all of that and take my chances, and then when maybe have a shorter life, but live with a better quality of life for that period. And I think that is a very important, interesting perspective on the patient-centered care approach. More on the slides, lots of very interesting links and videos that are really very informative, and some powerful patient speaking on those videos. So there's plenty of references also in the slides. I'll finish off there because I'm over time. I don't know if there are time for this group to ask questions or give comments, or whether we...
The room is booked for us, so
okay.
It depends on...
All right.
availability.
But I know people have got things to do and go, so do go and do your things if you need to. So I'll finish there. Any comments, questions, reactions? We can take a few before we sort of formally end. Yes.
Getting back to the.
Now you put your hand up earlier, and you were not happy with your healthcare, were you?
Mine was a depends answer because
Yeah.
I'm the caregiver of my family, so certain privacies and restrictions on what I can manage from my health portal restricts, for instance, my.
Sorry, is that the Kaiser?
Yeah, I'm
Yeah.
part of Kaiser, and I love the way I can manage mine, but
Oh.
my 13-year-old son has all sorts of privacy rights, and so I can't even make appointments anymore for him, but I don't think a 13-year-old takes that control. But he has a right as a teenager now.
So you have to go to him and say, could you log in?
No,
Could you?
it has to be a phone call. I can make it by a phone call, but I can't go online.
No, but that's my point, is that you have to sit your son down, get him to log in, and tell him what to do on
Yeah.
Yeah.
So
Okay.
it actually is related. My question is related. I lived in Germany.
Sorry, what's the lower age?
12. And under.
Okay, so
12 and under.
someone under 12
Under 12 is
with
allowed.
Kaiser
Then
could
at
not.
12 they have certain things, and by 13 most of it's locked to the parent.
Okay, but sorry, could a 6-year-old open their own portal with Kaiser?
If they were clever.
Well,
But why not? I mean,
But
yeah.
they can bring it down to school.
if there's a Kaiser My Health app on a
Yeah,
tablet,
sure.
then you probably. Anyway, sorry, I'm
Well,
interrupting.
it's
you.
actually related to that,
Yeah.
because after living in Germany, there was a lot, I was there, and there's a lot of, rightly so, worry and concern about security and privacy. And one of the things that we in the States are a bit lazier with our privacy security, but that gives us advantages in terms of being able to log in and see things and do things. And yet there's advantages and disadvantages for increased privacy and security.
Yeah.
What's Sweden's, where you are, what's
Well,
the use of the internet for
yeah.
managing things?
Now, I think there are two very interesting issues that you raised by this. First of all, there's the attitude to privacy, which formally the EU has taken, which is different to the US.
Yeah, for sure.
And part of that is simply the US has been, first of all, citizens here take a slightly different attitude, but primarily, my view is that it's driven by the industry and simply people saying, look, innovation, internet, important for the US. You wouldn't have Facebook and all of these things if you didn't have an open, Wild West on this. Government is persuaded and lobbied, so we have a pretty open, although in relation to health, with HIPAA and others,
It's a bit
it's
yeah.
different to out there in the commercial world.
Yeah.
So that's different for different reasons. Okay, EU, and also culturally, we take a different approach. As regards Sweden and what we do with the patient portals and other things, I think there are two things. First of all, there's a nationwide portal, which essentially Sweden is 21 different geographic health systems. So it's like Kaiser for Stockholm, Kaiser for Göteborg, Western region, and so on. These are public systems, and they all use the government portal, and they can do their versions of it, but the infrastructure is the government portal. And it's run essentially by government. Swedish people take a different attitude to their national and local government. So far, lobbyists and politicians are accountable. Well, we believe that our politicians are accountable to us, and that we can control them, and we don't have lobbyists. So that there is a fair degree of real democracy going on in Sweden, and we've got over 1,000 years history of this. So from your perspective, we have a touching, naive attitude towards government that is very dangerous. From our point of view, sorry, but ever since the Viking days, even our chiefs in the Viking days only were chiefs by consent, and there's much more can be said on that, and that we, unlike the US, we control our politicians and government. I think actually there is a slight naivety amongst the Swedish about this. But anyway, what I'm saying is that if it needs to be done properly and well, then the government will do it. And we can control it and trust that. So we've got this system, and it's so much more lower cost. It's not necessarily as customer friendly as it could be or should be. Now, the second thing is that within Sweden and many other European countries are moving in this direction. There's a special secure system, which is a little gadget that you plug into your USB, and you plug in, for example, your bank card. Now, to do bank transfers or any bank interchange, you can't just log on like I can do with my US banks. You've got to put this thing in, do the codes, do all this stuff, and it's fully secure. That's for the bank system. Now, the way we've gone in Sweden is for your health information, and for this information, we use the same system. So I couldn't open up my version, I couldn't start my version of the Kaiser portal without first signing up with my bank and getting all this and getting this working.
Yeah.
And then I could piggyback on that system for the secure. So now, interestingly, what that's saying is, if you trust it and it's secure enough for banks, then it's good enough for your clinical information. And everyone, and this has all
How
been...
were the citizens provided those little gadgets?
Well, this is the thing. You have to have a bank and a bank account to be able to do this.
Right.
So what it means is that those people who can't use this approach and the bank account
And the computer
can't do that. Now, Sweden, totally wired for many years, government subsidies for every family to have a computer, so it's much more coverage. But new immigrants and some less educated and some older people struggle with that and don't have that. So that way of going, the decision is made, we'll do a trade-off. To have it working well and have this system, we'll go that way. But it will mean some older people will have to have help to do it. And it being Sweden, there are people paid to help them and do it for them, and that sort of way. But it's still not quite. So it's trade-offs, different ways of doing it.
John, we have a question from someone online, and you
Thank
can
you.
read it yourself up on the screen, but it's from Kate, and she says, I was concerned by the notion that if people didn't like their care, they could, quote, get off the train. I don't think that's true for most people, either for medical system, economic, or socioeconomic, educational reasons.
Yeah, I think this is a very important point. I have a friend for many years, Ken Hillman, who's an anaesthetist in a critical care doctor in Australia. And he wrote a superb book about his experience and observations in critical care in Australia. And essentially the gist of this book is a series of horror stories and nightmares about dying in a critical care unit in a hospital in a high-tech way. And he's a real advocate for terminal care, palliative care, and good alternatives to dying in an ICU. And I think one area for the future, and one of the things I wanted to get to, was the whole end-of-life approach, which is totally unpatient-centered, and having alternatives to dying in hospital, and being able to be confident that your pain will be controlled and you will get support and you can have access to hospital if you want it. And if you're confident about that, then it's a viable option then to spend your last... This is something we will all face. I know this is America and you don't die here and you don't, and you certainly don't think about death, but all of us will have longer or shorter where it suddenly becomes clear that actually our days are numbered. To have an alternative to being in the ICU and to dying at home, I think is very important. And what Ken explains in this book and shows very well is once you're on the train and you get admitted from one place to the next place to the next place, it's very difficult to say, enough, I'm out of here. I'd rather take my chances. I don't want to take this anymore. You go along with the ride. And part of it is especially because we believe we may get well again, and secondly, we don't want to cause trouble, and thirdly, we just do not have the energy and health to do that. Which takes us to another thing, which is the whole importance of advanced directives that are legally enforceable, and to having, there's the IHI have a program now called the Conversations Project, which is about formulating your own advanced directive and ways to get it legally enforceable so that it can't be ignored by the hospital. So that speaks to that question.
What's the name of the book again and the author?
Ken Hillman, Hillman, It's on Amazon. Oh, I've forgotten the name of it. It's not as bad in terms of continually gloomy, but there are some chapters which are difficult to finish reading in terms of what the experience has been like for some people and could be like for you in dying in an intensive care unit. Yes?
This is, I mean, it's fascinating because ultimately it's, a service design challenge, what's been done in Sweden. The thing is, coming from Italy, where we have a national health system and a complete distrust as opposed to Sweden, to the government, towards the government and institutions.
And a much closer family. I mean, it's primarily family that gets you through.
And there is this sort of psychological hierarchy. So I can't really see a lot of people wanting to go against doctors, nor physicians or hospital staff and administrators being willing to change the system for fear of losing authority. And I would imagine that similar challenges might happen here in the States, if nothing else for economical reasons. So how do you really generate buy-in, both from the user perspective and the provider perspective, when measurable outcomes are so difficult to track?
Yeah. There are so many elements, different aspects of what you say. The quick answer is it's got to be financially beneficial for the different stakeholders to go down this route. The second answer is patients have to drive this in different ways, through different pioneers, and ideally by doctor patients and by others who are not, oh my goodness, we've got another hysterical so-and-so, but are just talking matter-of-factly about their experience and what they'd have preferred. And then it has to be an organised movement in various ways. And I think the US is leading in that sense. I think the Netherlands, there are certain patient groups and others that are taking a lead in this. So it's patient-led, patient-organized. And then there are ways to, quote, activate patients, different interventions or ways to make people more aware. The AHRQ has a number of fantastic programs on this front. Questions are the answer. If you Google AHRQ, questions are the answer. There are some superb videos and put very well. And basically what this is doing is going direct to patients with YouTube and videos and others and saying, ask your doctor these questions and be more assertive in these particular ways. And there's a couple of great videos of people, a guy going to a phone shop and asking all of these technical questions about the phone and the plan, and then the guy in the examining room and the doctor says, any questions? No. And the contrast is remarkable. So that would be the second thing, that I think it has to be patient-driven, and there are different ways to enable and empower patients in different ways. There are other things to be said, but I don't want to go on at too length. But I suppose the third thing I would say is look at the examples in advanced areas, like I think women and maternity care, that's driven. Maternity care now is much more patient-centered than it was 10 years ago even. Secondly, in mental health services, there is some interesting and important user-led movements, and in some mental health services it has had an impact. So I think for certain patient groups, certain patient diseases, we can see the beginnings of more patient-centered approach and patient-centered care, and to take those as examples. But I'm sorry, it does come back to the basics of money, costs. Is there money in it for us? Or in Sweden is, yeah, but what are the other uses of that finance, and how do we decide the best use of the finance, and how far down this route should we go?
John, we have another question from cyberspace. So it's, what do you think is the best way or good approach to increase frank dialogue between patients and doctors about clinical care concerns? Is it broad topic, so maybe sum up?
Well, I do think I think there are there are a number of things here. First of all, some training for doctors. When you see yourself on the video with the actor patient and how you're handling it, and you have the debrief with your peers, other doctors making comments, maybe if you'd done it more that way. Those trainings are very good, but they tend to be for the people who are already interested and quite good. Secondly, but you can't just rely on that training. You have to have the environment that supports the practice. And there is only so much that you can expect of a physician, given the turnaround time and the time they have with individual patients. And when you look at the Kaiser, for example, the Kaiser, it's not just Kaiser, it's all of the health systems now, how much time a primary care physician is able to give to each patient. That's partially a problem. Second thing I'd say is medical school training. That's important to get people when they're young, and I think younger people are generally more aware and open to this. Thirdly, selecting students, not just for their grades and scientific abilities, but for their ability to relate to people, and especially having a certain humility. But I do think if I was practicing actively now as a doc in the States, I think it would be a lot of this would be pretty theoretical, and I would need some significant changes in how my practice and clinic was organized. And I do note from some of the examples that actually it's family practitioners who've actually just had to kind of opt out and set up their own practice with a few other like-minded people, and simply accept a much lower income and see fewer patients, but the satisfaction of working in this way, they prefer to do it that way, and that they can afford to do that.
There's also a question, can you provide a link or tell us where we could find the Berwick statement that you mentioned?
Well, it's on the PowerPoints. There's the link, the YouTube link on the PowerPoint. And if you just, I suppose the other way would be Don Berwick, Patient-Centered Care. But the best way would be to use the links on the PowerPoint.
Related to what you were saying about students and stuff, I was particularly interested because I am just currently applying to a Master's in Global Health at the Karolinska Institute. And I was wondering...
Oh, you're on Thompson?
No.
Oh, okay.
But I was wondering what you knew about like differences between education of people, medical students here, or public health students here in America versus in Sweden, and how those differences can affect like the distribution of public health.
Well, okay, you're talking about public health. Now that's very different to being a medical student going into practicing clinical medicine. Now, as regards public health, if you did public health in Sweden, you would have a much more social, communal approach and lots of very interesting projects. Having said that, I think there are some very interesting projects here in Los Angeles County Public Health Department, and some of the different projects that are being done here, and some great things going on at the School of Public Health. But in Sweden, what you would find is that you would find the systems, the healthcare systems, the politicians, the patients and others, wouldn't have a problem with public health programs, and that it's a much more, the direction my PowerPoints go is to talk about integrated public health, where public health is viewed as closely related to health care, but it's community-based in different ways. So you get an insight into different ways to doing it, but in some ways it may be appropriate in Minnesota, for example, or in Wisconsin, where they do have a much more public-oriented, much more communal or social-oriented approach to healthcare and health programs. But I do think the States is moving in this direction. One of the best references on this is the IHI Triple Aim working paper, and the work that is being done by the IHA and others under the name of Triple Aim. And the Triple Aim is population health, costs, and patient outcomes, which is satisfaction and clinical outcomes. And it's a way of conceptualizing the way how health systems like Kaiser and others, and how ACOs are moving into population health management and combining that with health care as well. So I hope you get it, and I hope to see you over there.
John, we're running out of time on the webinar portion. So if there are further questions, and you have the time, it would be great to talk to John after the presentation.
Happy to.
But we need to.
But we'll finish off formally now. Yeah. So thank you very much for inviting me and for letting me give this talk.